Hello, welcome to live stream. Let me know if you can see me and hear me, because today do we have just absolutely the most exciting topic that I know you all are looking forward to, which is we're going to talk about how to navigate open enrollment, aka the time when the portal into hell that is American healthcare opens, and you are allowed to enter it. And you may or may not make the right guesses about what you are going to do. I was going to make myself espresso, I just remembered, and then I had some technical issues, and I now see that my espresso maker is on. So I may abandon you for 2 seconds to turn off my espresso maker. I'm a little bummed because I really wanted an espresso, but I feel like it'll take too long to make it. But I don't want to leave my espresso maker on for an hour and a half during this live stream. But everybody can hear me and see me. That is good. Had to lower volume. I could hear too well. Sorry. It doesn't look like I'm popping on the audio, but I'm just very loud. So I will be right back to turn off my espresso maker so I don't burn down my house. Okay, good. House won't burn down. I'm a little bummed because I was just waiting for the water to heat up. I'd already gotten the the teacup out and already packed the coffee. But it's fine. Honestly, I've already had 2.5 cups of coffee, so I didn't really need the espresso. But it is monsoon weather in Portland right now, and it means that I absolutely have no interest in going outside. And the risk of just sitting on the couch too long with the cat on my lap means that I may or may not be motivated. So coffee is like meant to overcome it. Your intro was also much louder than Aaron's audio. Well, Aaron's traveling, so I also got blasted by my own intro audio because I started it while still listening to Aaron's stream. So David says, I missed Aaron live from London. That would have been fun too while I look for my travel gear. I know. I don't know if Aaron was super stoked about going to London. The weather in Portland is almost, it's worse than London, I think. So maybe that'll make Aaron feel a little better. I think he just was not excited to travel. Which is I'm the one who loves London out of the two of us. So, and I know it's going through a lot right now, but I still am I'm a little jealous that I get to go to London for work. But I wasn't jealous enough to fly there, even though flights are pretty cheap right now. Aaron says, should I entertain people while you're away? It's okay. I'm back already. All right. David says, so I don't get to ask about why my insurance company would only give me 15G every 7 days instead of 60G for 3 weeks my doctor prescribed. We actually can talk a little bit about that kind of problem. Without being terribly specific on your own medication, we can talk about what to do when your insurance company has quantity limits on your medication and how to know that this is true, and then also how to appeal that decision. Because you can often appeal those decisions. So yeah, we can maybe talk about that. Should we dive in, y'all? Because there's a lot to unpack when it comes from American healthcare. So if you do not know, welcome. This is Talking Dough and Eating Donuts. Because in America, healthcare is a business, and for a lot of people is their number 2 expense after housing. And for small businesses, it is the number 2 expense after paying for employees. That means that open enrollment is in fact a financial related topic, and I hate to admit it. But because I really wish that healthcare was not so outrageously expensive and such a gamble in the United States. But unfortunately, this is a situation we're in. So every year on Oh My Dollar, November is called Healthcare Month. And that is because open enrollment on the healthinsurance.gov marketplace is open from November 1st through December 15th this year. But we're going to talk about when you can access that if for some reason you missed open enrollment, because there are new expanded eligibility year round if you have a low income for certain things. And then also special enrollment periods. And this is also when a lot of people have open enrollment at their jobs. So November 1st through 15th is when a lot of people have open enrollment at their workplaces. But it varies. I mean, like I worked at a organization that made open enrollment videos, like educational videos. And, I saw open enrollments for employers that were anywhere from, February to December. I mean, it's really like all over the map as far as open enrollment. My last job open enrollment was in August, but then you were open enrolling for the next year's plan that started in January. So there's all sorts of like weird things that can happen. I worked somewhere where open enrollment was in the summer and your plan started in the summer, but the plan year was still dictated by like your out-of-pocket maximums, and your deductibles were still dictated by the January through December plan year. And this was really important to me because I had already hit my out-of-pocket maximum for the year when open enrollment opened in August. And so the question for me was, if I switch plans, I'm going to lose out on all of that out-of-pocket maximum that I've already built up, and then it's going to be reset again in 6 months. Anyway, let's kind of talk about it. Eric says, we have 2 elections, one for benefits and one for people that have a hand in some of those benefits. Accurate. And I actually am going to talk about the Inflation Reduction Act because it actually had a pretty significant impact on expanding some of the opportunities to actually get healthcare, expanding a lot of the subsidies, extending things that were implemented during coronavirus to now go through 2025. So yes, Congress has a huge impact on your access to healthcare if you are a United States resident. And additionally, the Supreme Court does, which I have talked about ad nauseum, but we don't need to talk about the Supreme Court today because guess what? We don't get to elect them. So, which is its own situation. I will say I've been listening to a lot. I started from the beginning. I've been listening to this podcast called 5-4, which is a podcast by 3 lawyers about why the Supreme Court sucks. And generally, most episodes, they go through one decision and break down the legal analysis and critique it that the Supreme Court has made. And it might not be recent decisions. Like a lot of these are long ago historic decisions, and they'll read through the legal analysis and kind of attack it from a legal perspective. I think I've listened to like 50 episodes of 5-4 now. And because of that, I was cleaning my house yesterday and I think I listened to like 4 hours of 5-4. And because of that, I'm feeling very spicy about the Supreme Court. But we really don't need to add any spiciness to my feelings about healthcare in the United States. Philip says, recently got news for my insurance that my monthly premium next year goes up from $1,230 to $1,360. Self-employed, self-insured. Whoof, that is high. I'm assuming that's a family premium. I hope that's not an individual premium. That is wild. This is actually brings one of the first recommendations I have for people. Because it is open enrollment, as long as it is open enrollment for you, I highly recommend, because of what has happened with the Inflation Reduction Act, that you do not just re-enroll automatically without at least looking at your other options. So if you are getting health insurance through the marketplace, which has only gone up over the past couple years, and predictions are that even more people in America are going to be getting their healthcare through the marketplace exchange, do your research. Do not just re-enroll in the plan that you have because, 1, plans have changed. Premiums have gone up and coverage has gone down for a lot of plans. 2, because of the Inflation Reduction Act, subsidies have now been extended for people that make less than 500% of the poverty level. Through 2025. So for the past year, since the Build Back Better plan, we have made it so that if you are a median, not just a low income person or family, and you are getting your health insurance through the marketplace, you are able to access subsidies. And because of that, these subsidies can be quite substantial. There is no longer a subsidy cliff, because it used to be that if you earned just a little too much, over 150% of the poverty level, you would just fall off the subsidy cliff. And Kaiser Family Foundation, which is not affiliated with Kaiser, the health insurance plan, which I will be talking about because it is one of my options for open enrollment. It's just they share a common ancestor. Anyway, so the Kaiser Family Foundation did an analysis that showed how much getting rid of this subsidy cliff where people just fall off is going to save folks over the next couple years. So there are a lot more options now. And then the big one I want to talk about that a lot of people do not realize, and a lot of people may just choose to re-enroll, is that finally, 10 freaking years later after the ACA passed, we have gotten rid of the family glitch. What is the family glitch? Well, it used to be that, I fell into the family glitch one year, so let's talk about it. So if you or your spouse has an option to get health insurance that is ACA compliant through their workplace, then they do not qualify for subsidies on the exchange. That makes sense, right? Because for some bizarre reason, we've decided to tie healthcare to your employment in this country, which is not a terribly sane way to do things. But because we have decided that that is part of the cost of doing business as an employer, then we don't want the government to pick up the tab for your health insurance over your employer. However, what ended up happening is that means that if you are able to be covered by your spouse's employer insurance, but it's really extremely expensive to cover you or your kids under your spouse's insurance, you still were not able to access subsidies on the marketplace. So there's an affordability test, which for 2023 says that you can go get marketplace subsidies for your health insurance plan if your employer offers you insurance, but it's too much. And that too much measurement is 9.16% of your household income. But it used to be that was only coverage for you, the individual, whoever is being employed that is offered it. So let's say, like, for example, my partner's health insurance is $0 for them, which was a situation that we were in. But let's say to put me on it, it was going to cost $800 a month. $800 a month is greater than 9.16% of our household income. But because I was not the employee, then I would not be able to then go, this is unaffordable coverage and access the subsidies on the marketplace because I could be covered under my spouse's insurance. And this is called the family glitch. This is for a lot of people, they fell into this. Obviously, a lot of families, the kids are covered under a parent's health insurance, but often because the costs of providing health insurance have gone up so much, especially for small people that work for small employers, the covering your dependents, possibly your spouse, your domestic partner, and your kids had gone up so much. The average Kaiser Health News found in a survey that this year, the average amount of money spent on premiums for a family of four is $22,000. And that's for smaller firms. So it is really important to understand just how much fixing the family glitch will change things for a lot of people. And a lot of people don't realize it because we've been stuck in this situation with the family glitch for 9 years. Wait, not 9 years, 8 years. 2014 was when, when the ACA really went into effect. So, it's important and useful for people to understand that the family glitch is now gone, which means if covering your family under your workplace provided health insurance costs too much, or you are self-employed, but your premiums buying individually, like directly with the insurance company, are really high, please look into healthcare.gov. Actually go look on the marketplace because you have a lot more options. So, there are a lot more people for which they are going to have access to subsidized plans this year, and that they're going to be able to access them, but you cannot get a subsidy if you are buying your insurance directly from the insurer. You can only do it if you go through your state's marketplace exchange or your own health insurance, or your state's exchange or healthcare.gov, depending on which one is the marketplace in your state. And, for families, it's up to $100,000 of family income is 500% of the poverty level. I mean, it goes up depending on how many dependents you have. So it's hard to say, specifically depending on how many people are in your household. But it is really important to understand that there are a lot more subsidies available now through 2025 on the health insurance marketplace. And just because you made the best choice in the past doesn't necessarily mean that that is the best choice for next year. So yes, I went off on my soapbox. Atabay says, or Atabay, sorry, I think it was Atabay. You told me and I forgot. Atabay says, my job currently does open enrollment before the marketplace does. That is very, very frustrating. Yeah, I mean, the thing is still, if you get affordable coverage on the, through your employer for yourself, unless it is more than 9.16% of your household income, you won't have access to the marketplace anyway. So it doesn't really matter. I mean, you can buy it on the marketplace, but you won't get any of those subsidies or the benefits. Philip says, nope, single. Philip, please look on your marketplace exchange, because that is a very high premium for one person. Malin Hartwell says, my individual insurance for one was about $1,000 a month, self-employed. Yeah, it is really, really expensive. I mean, that's why I didn't have health insurance until the ACA passed. Literally, no one would insure me, and it would cost way more than I made. I wasn't insurable because I have rheumatoid arthritis, and that is a pre-existing condition, and pretty much the only thing I needed coverage for. So no one wanted me. And I couldn't buy it. It wasn't available. I mean, there was no one that would sell it to me. So in some states prior to the ACA, there was this thing called the high risk pool, where you could pay money in a high risk pool, which was essentially, they made a giant pool of the people that are too expensive and too hard to get health insurance. And you could pay $1,000 a month to get really crappy coverage through the high risk pool. But it was not affordable to me, accessible to me. And my state didn't have a very good one. David says, I pay 21% at my employees, but they are upping my copay. You pay 21% of your income? So if your income is below about $60,000 for an individual, you should check your state health insurance exchange, because you would qualify for a subsidy if you're a single person and below about 60%. And you might also just have better options because you would qualify for a subsidy because 21% is too high. Malin says, my agent reshops each year and has found a better deal. That's good. I'm glad. David says, I'm skeptical about how hard they work to keep it down at my place. I mean, that's the thing, is I got feelings. I don't want to. Eric says, that does sound like a family glitch. Man sakes alive. Philip says, thanks, I'll check out the current requirements. The special medicine I need to have each month is only covered by the highest gold tier one on my insurance. Okay. We've gotten into so much stuff, and I do think that before I dive into talking about how you check your medication, possibilities for medication coverage, which I do really want to talk about, because my medication is $12,000 a month, and it is the number one consideration for me when it comes to picking health insurance, because I am otherwise a pretty young healthy person who needs a $12,000 a month medication. And that means that it is really expensive. And there are a lot of considerations when it comes to medication. So I'm going to talk you through the different options, and I'm going to tell you about what I did when looking at the options that were available during open enrollment through my spouse's employer for getting coverage. But first, I do want to define a few terms. The first term that I want to define is understanding that there are different types of health insurance plans. And I think this can get really overwhelming for people, but there's really just two things you need to know about from kind of well, let's put them in the first category. The first category is what type of health insurance plan you are. And what I want you to remove from this is this concept of HDHP, which is a high deductible health plan, because any of these types of plans could be an HDHP. What the type of plans we're talking about has most to do with what kind of providers you can access and what kind of bureaucracy you're going to have to navigate in order to get access to those providers. So there are kind of three main types. And once again, we're talking about commercial insurance. So what is available from your employer or what is available on your state marketplace plan. This is different for Medicare and Medicaid, which are way beyond the scope of what I can talk about today. But I can talk about when you'll qualify for those. So, okay, there's three different main types. They like to invent new names, but roughly these are the types. So the first one is called a health management organization, or an HMO. What is an HMO? An HMO is essentially what a single payer, single provider kind of health plan. So it's very equivalent to what you would experience in like the NHS in the United Kingdom. However, it's done under the American hellscape that is our capitalist-based health insurance system. So the big downside of going for an HMO for people is that you're going to only be able to get things covered if you go within their network of providers. For a lot of people, the largest HMO and the person that invented HMO, partially because he had Nixon's ear, but we'll move on. The person that invented HMO was Kaiser. And so for a lot of people, the HMO you're going to have access to is called Kaiser. Kaiser, here's the thing, all health insurance, despite the fact that we have this federal plan and this federal marketplace, it's actually regulated at the state level. Because of this, what kind of access and what kind of experience you have on an HMO is going to end up, and any insurance plan is going to be highly dependent on your location and your state rules. So in our state and in our city, Kaiser HMO is one of the largest employers in our entire state. In Portland, you will most likely get all of your providers in one big facility. The hospital has the pharmacy, it has the rheumatologist, it has the endocrinologist, it has the primary care physicians. All of this stuff is, it has the infusion centers. It's all in one building. The advantage of an HMO for people is that usually you are going to have lower costs when you engage with the healthcare system. Also, for a lot of people I know that have executive function issues, HMOs, while they can be frustrating to work with, tend to be more clear about what you need to do to get the healthcare coverage. So, one of my friends that has ADHD said that for her, Kaiser is like the best of all of the options for her as an HMO because everything is in one building. It's really clear what you need to do. I first got diagnosed on the system. I had rheumatoid arthritis for about 8 years prior to getting health care coverage, but I didn't want to get it taken care of. I mean, not that it's really taken care of, but I didn't want to get it on my record because I didn't want it as a pre-existing condition prior to the ACA going into effect. So I originally had Medicaid when the health insurance passed. And so it's called Oregon Health Plan here. And at the time, Oregon Health Plan was administered through Kaiser. So my first experience of being a properly insured adult was under the Kaiser system. About 6 months into having Medicaid, which actually ended up being much shorter period of time into having Medicaid because it was impossible to cancel because they did not have the bureaucracy worked out. I got covered under an employer plan, but that same employer plan was Kaiser. And that is because Kaiser is one of the largest employers. It's like the only option if you work for most government employers here in Oregon. And so, I was able to just kind of continue on at Kaiser as my primary insurance. I first got my official diagnosis with rheumatoid arthritis under Kaiser. Here are the advantages. One, it was incredibly easy to know who my specialist was. If you have an HMO, you are going to have to do everything through your primary care physicians. You're going to have to pick a primary care physician. In the UK, this is like your GP is kind of your funnel into the rest of the NHS. Here, you will get a primary care physician. You either get one or you will pick one, depending on how easy it is and how much you advocate for yourself. And then that person will be the person you get a referral to any specialist. So you can't just call up the dermatologist and be like, hey, I need a dermatologist. You're going to have to call up your PCP, go into your PCP, then the PCP is going to assign you to a specialist and go like, yeah, actually you do need to go see the dermatologist, or yeah, actually you do need to go see the rheumatologist. I was able to do my initial intake appointment. Then at the intake appointment, they were like, yeah, your joints are fucked up. So yeah, you should probably go see a rheumatologist. And I was like, and I have a family history of arthritis. So they were like, great. Okay. We know what you have. Go to the rheumatologist. When I went to the rheumatologist and when I got my labs and when I got my vaccines and when I went to the pharmacy, it was all in one building. So it's very helpful for someone that's like, oh my God, I have to make an appointment. I have to find a provider. I have to find out if they're in network. No, it was great because I just like all went in one building. The downside of this is, one, if you've got a PCP that just won't refer you out to things, you could have trouble accessing medical care. Two, if you've got a weird medical problem, something that is outside the scope of the provider. So you have a rare disease, you have something that isn't presenting kind of in the standard ways as far as medical diagnosis is. A lot of people are very stressed by being in an HMO because usually there is zero coverage for out-of-network providers. So if they aren't in the HMO, you're screwed. However, some will cover out-of-network if it's something their providers can't do. So the experience really varies. But if you have something, like someone on the forum said that they can't, they have a kid with a rare condition and they love it because they love Kaiser. They don't love that their kid has a rare medical condition, but they love Kaiser because it's very straightforward. They always have to refer out to a specialist, but it's automatically going to be covered because nothing is, because they don't have a provider in their system for that type of disease. And so for them, they find that it's very easy and clear. That is what a lot of people like about HMOs. Unless you get on the wrong side of it, like I have a friend whose son has a unusual presenting eye problem that had to be referred out by Kaiser. And in order to get that covered, it was very frustrating because they had to go through reams and reams of being like, no, this is a problem. We need this surgery covered. And before they could get Kaiser to actually cover that out-of-network cost. So, because Kaiser finally admitted they don't have anybody within their HMO that can handle it. A lot of people's experiences with going through an HMO is that if you have like kind of a more standard thing, so, you have a heart disease or something like that, something that is a very common ailment and has a pretty standard treatment protocol, then HMOs can be great because everything's in one building. It's very clear. You know how much you're going to pay for a visit to the specialist. You know how much you're going to pay for a visit to the hospital. You know how much you're going to pay to get your medications from the pharmacy. But if you need something rare, like, for example, I needed something, it wasn't even rare, it was just expensive. I had to do, which is a thing that I also have had to do on PPOs, but I had to do a thing called fail first. Some states have banned this, but not very many of them. I had to do what's called step therapy or fail first therapy, which meant that they had to try all the cheaper treatment options for me, and I had to show no success on those treatment options before I could be put on the expensive one. So it's very common on a PPO, where you're not within this, HMO system, that you may experience having to go through step therapy or prior authorization for a medication. But I had to essentially spend 6 months failing on the cheaper options, which for my disease were methotrexate, which is a drug I tolerate really poorly because it's poison. A lot of people are on it, but it is also like, it has a poison hazard warning label on it. I tolerated it really poorly, and it didn't have a significant impact on me. It's still not a super cheap drug, but it's a lot cheaper than the drug that I am on. I also had to try sulfasalazine, which was essentially a placebo for me, but is very cheap. And I had to try hydrochloroquine, which you might remember from Trumpers thinking that it was going to cure COVID. But I had to try all of those drugs and fail on those drugs prior to being put on the biological. The biological that I'm on is considered a first-line treatment for most autoimmune disorders. Biologicals are like completely treatment changing, world changing for a lot of autoimmune disorders because they are medications that essentially target the root cause, which is a misfunctioning immune system, but they're very expensive. Biologicals are not compound drugs. A lot of them are not covered under. What is the word I'm looking for? Oh, a lot of them are still covered under patent in the US because they're newer. Like the first one came out in 2000. Well, kind of came out in 1998, but in like 2001, large scale in the US. So a lot of them are still covered under patents in the US. And so there aren't the generics, which are called biosimilars, available. And like I said, my drug is now $12,000 a month in the United States. So I had to do that before I could get on the biological. I finally got on the biological, and I was better within 3 weeks. I mean, I went from like not able to use my hands to transformative changing. Here is the thing to know about my experience with needing an expensive medication on an HMO. Yes, it was frustrating. However, it was frustrating. However, my rheumatologist, because rheumatologists, all they do all day when they work in an office that works with more than one health insurance company, like my current rheumatologist, which is not under an HMO, has an entire team of administrators. And most of those administrators' jobs are dealing with prior authorization with health insurance companies because as a rheumatologist, they treat autoimmune conditions. What do autoimmune conditions need? Really expensive, newer medications. What does that mean they do? They spend all of their time and a huge amount of administration costs that gets passed on to all of us as patients just dealing with filing for prior authorizations with insurance. Because I was under an HMO, my rheumatologist, while they did have to go through those steps, they were appealing to their own employer because they're employed by the insurance company. And there was just way less paperwork that needed to be done and way less gambling because that is what it ends up coming down to. If you go with a PPO, you're going to feel more like you're gambling when it kind of comes to these things. So, pros and cons. So, when considering an HMO, the thing to understand is, yes, it might be easier, but you're going to have a limit of providers. You really need to look into how many providers, what the access is like. One of the things that got brought up to me was that it used to be really easy to get appointments when I was on Kaiser. I've had a lot of friends that have said that they haven't even been able to go to the main facility that's really like close to me, and they've had to make their appointments for like primary care and things like that, or labs like way farther out, and they don't have a choice where they can go somewhere else because it is an HMO. Essentially, if it is considered emergency and you need to go to get out of network, then your HMO will have to cover it. But it'll be considered out of network coverage, in which case you may not have your same out of pocket maximums or deductible apply. So that can be the downside. I spent a long time on HMO, but what do you need to know about the other two kinds of plans? Well, they're called EPOs and PPOs. The PPO is the most common one that you will find, and that is called a preferred provider organization. And you have a lot more flexibility about what kind of providers you choose, but you may have a much higher deductible. So for a Kaiser plan, it's quite typical that you have no or an extremely low deductible, like $0 deductible, and you just pay copays every time you go see the doctor or get a medication or a treatment. And those are pretty clearly disclosed. But on a PPO, it might be a high deductible plan, or you might just have a higher deductible, but you're going to be able to choose from within a network of providers. And for a lot of people, the PPO might be the only option if they do not live close to providers that are covered under an HMO. So we'll talk a little bit about how to find out if a provider is covered under a PPO. So that's what a PPO is. It still will have kind of the same things of copays, coinsurance. I can define the difference between those two if you don't know. One is pretty much a percentage, and a copay is a flat amount. That's all you really need to know. And they can be low deductible plans, but usually instead of a PPO, if you're going to have a lower deductible, but it isn't an HMO, you will have what's called an EPO. So a EPO health insurance plan is an exclusive provider organization, and it's sort of like a more distributed version of a HMO. The EPOs will have usually a larger network and of providers that they cover, but you can only go to those providers. So it's kind of similar in terms of an HMO where you might not be able to get any coverage for out-of-network providers. Whereas on a PPO, you might have coverage for out-of-network providers, but you're going to pay a lot more than you would if you went to a preferred provider organization. Does that make sense? I have talked for a long time, so I'm going to look at the chat. American Healthscape are us, correct. Atabay says, I'm on MTX and I hate it. I know, I really hated it. My sympathy. I know it works really well for a lot of people. And you know, there's a lot of people that can be on methotrexate. MTX is what we're referring to there. There's a lot of people that can be on methotrexate and tolerate it really well long-term. And it's a very cheap, older drug, and so and you know, it is still considered one of the first line treatments for a lot of autoimmune disorders, and it's used in much higher quantities as chemo for people with cancer. For me, I just had terrible side effects from it, and I didn't get any of the benefits from it, so there was no point in staying on it. But I do literally every year have to prove why I cannot be on methotrexate as opposed to my biological, even though they're often used in concert together. One of the big things for people with methotrexate is this is just a random aside fact for anybody that's interested. But for methotrexate, a lot of people get extremely nauseous when they take it. And because of that, it's like, it can really suck to be on long term because you have to plan, you know, a lot of people do their shots like once a week for methotrexate, or they'll do like an infusion every like couple weeks, but they have to like plan their whole lives around like being completely terribly nauseous for a day. A lot of people's hair will also, they'll have some hair loss, not like quite on the level of, what would happen to you if you get certain kinds of chemo. But like, you know, a common co-prescription that you can get is folic acid in order to try to combat that. And then another thing that a lot of people don't like is that you cannot drink alcohol when you're on it. You can have like 1 or 2 drinks a month. But I don't drink, so it's not a huge problem for me. But I did drink when I was originally on methotrexate. And I guess it helped me save money overall because I was like, oh, I guess I can't drink anymore. But it was socially frustrating for me because there were far fewer good non-alcoholic options available, and I was a fundraiser, so I spent a lot of time going out to bars and fundraisers and stuff like that. Now we have better options because people are starting to do that. Atabay says, and yes to hair loss. Friday night so I can be sick Saturday. Oh, it sucks when you have to, assuming you work a Monday through Friday, but like it sucks that when you have to like arrange your schedule around the idea of being sick like on your day. Like if you work Monday through Fridays and you're like, oh, I have to do it so that I can be like totally ill for one of my off days. It's just a bummer. I'm sorry. Okay. My current plan is an EPO, Blue Cross Blue Shield in Tennessee. So, Yes, let's kind of talk about some of the like misconceptions that people have around health insurance. Because one thing that I've run into, as someone who currently has Blue Shield, and as I have documented several times on this live stream, Blue Shield has actually been really shit for me this year. Because of copay accumulators, which I've talked about ad nauseum. There is a lot of people who do not realize that health insurance is in fact regulated at the state level. And because of that, one thing that you run into is people being like, when I initially got Blue Shield, a lot of people were like, oh, this is the Blue Cross Blue Shield is the gold standard for health insurance, blah, 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 blah. Here's the thing. It's really just a brand name that can be slapped on different health insurance plans in each state, and it's regulated at the state level. And because of that, what kind of plan you get has totally different thing to do with someone's experience in Louisiana with Blue Cross Blue Shield and someone's experience in California, which have incredibly different regulations when it comes to health insurance, is going to be wildly different. And then another thing to understand is that this came up when I was trying to decide if I want to do Kaiser again, and I was talking with people that have Kaiser in places where Kaiser has a very big health management organization structure, like in Portland, because Oregon, so many people are employed by Kaiser. So state employees have Kaiser. Because of that, there's this huge infrastructure around it. And so my experience having Kaiser in this state is extremely different than someone's experience in another state. This is also a factor when you're looking at an EPO or an HMO. Also, Hawaii has completely different health insurance regulations. And frankly, they're so complicated, I won't get into them because I don't think I have many viewers in Hawaii. But they're much more complicated in Hawaii because they have they're allowed to do just whatever they want. And generally your health insurance will be better in Hawaii. But you may have fewer options available to you through your employer if you work through a large employer, if you live in Hawaii. And that's because a lot of the plans that people in mainland US have access to do not meet the high standards for Hawaii. So it's also important because if you live in Hawaii, you don't want them to be like, your nearest provider is in California, which is it is important, right? If you live that physically far away in Hawaii, Alaska, Puerto Rico, that you need to make sure that there are options available for you in the provider network at all. And if you are on an HMO so Kaiser, for example, there are Kaisers in every state. However, if I have Oregon Kaiser and I go to Colorado, which also has Kaiser, I can't visit a Kaiser. I can't go for a routine visit to a Kaiser medical facility there. It's not in network. My in-network coverage is only here. I actually have a friend who was Oregon-based, has Oregon Kaiser, and they couldn't even call the Kaiser nurse line when their kid got a small illness and they were out of state because they were outside of the jurisdiction of that HMO plan. And so they called and were like, what state are you currently in? And they're like, oh, we're in the Grand Canyon. And the nurse line was like, well, we can't even give you advice over the phone because it's not part of that regulation. However, all ACA compliant plans that you might get will have they do have to cover emergencies out of network when you're out of state. So even Kaiser, even a really restrictive HMO, if you have a emergency and you get taken to the nearest hospital and it isn't a Kaiser facility, if it is deemed a true emergency, which is a thing that you might have to fight your insurance about, but if you get into, a healthcare crash or something like that, they do have to provide coverage for it, but it will be subject to the out of network coverage. Ablejack says, what plan equivalent am I on? So Ablejack is on TRICARE because Ablejack is employed by the military. And for TRICARE, you're essentially on it's a weird one, but it's in between a hybrid EPO and an HMO. It's kind of a hybrid, I would say. It's special. TRICARE is special. Atabay says, I don't understand why they make these medications so expensive. It's a business, more money in treatment than the cure. Correct. I can give a little bit of information about why biologicals are so expensive. I do also want to share my experience of just my one drug that I'm on. So the one drug that I'm on, when I got on it, the list price was $800 a month, which sounds like a lot. I paid a $40 copay, and I was willing to pay a $40 a month copay for it. Now my medication is $12,000 a month. It has been 8 years since I got on this medication. And in that time, the only change that has happened to the medication, besides me switching into a actual cheaper delivery method for the medication for cost reasons, the only change that has happened is that the biosimilar has been approved elsewhere in the world. So because the biosimilar, which is similar to a generic, but it isn't quite the same because a biological is not a drug until it is in your body, and it's not a compound drug, so they can't just mix A and B together and say, hey, look, we mixed A and B together like the brand name of this drug, so we're the same, we're generic. So biosimilar, it has to show that it has the same effect in a clinical setting as the biological, but it can't have the same components, essentially. There's a couple of reasons why biologicals are so expensive, but one of the reasons they're so expensive for Americans is because we do not have price caps on them. So in other countries, especially in countries with nationalized healthcare systems, they will do the negotiation in mass. In the US, they are doing the negotiation freaking ad hoc. Each insurance company is negotiating with the pharmaceutical company, or the pharmacy benefit manager is negotiating with the pharmaceutical company. So because of that, they can charge us whatever they want. The other thing is that their patents keep getting extended. So my drug, one of the reasons the cost has gone up so much is because other countries, the patent has expired for my drug. And because of that, the biosimilar is available. The National Health Service in the UK switched to the biosimilar of just my drug when it became available. And in 1 year, they saved £279 million just on the cost of my drug. And they had a much better negotiated price. If I went to Mexico to get my drug, it would cost me about $800 a month, as opposed to here, which cost me $12,000 a month. However, I can't go to Mexico and get my drug because my insurance company won't cover it because that is an out-of-network pharmacy. So I'd have to pay completely out of pocket for it. The other, so that's one of the reasons literally, I have on this live stream read the shareholder annual report for the manufacturer of my drug in the US. And they said the year that the biosimilar was approved in the EU and the UK, lower unit demand, translating to fewer people taking our drug because they've switched to the biosimilar, was offset by higher unit prices. And what is higher unit prices? Well, the cost for my drug, the market cost for my drug for me, a drug that I had already at that point been on for 6 or 7 years, went up 40% in that year. And essentially what they did is they jacked it up on US consumers. Why are U.S. consumers captive? One, because our health insurance situation is a freaking capitalist hellscape. Two, they keep extending the patent for the drug by buying other patents for other drugs or medical devices and integrating and expanding those. So my drug currently has a 39-year patent in the U.S., and they are still trying to extend it. However, one of the big pieces of news for people that are on biological medications is one of the most used biologicals in the United States, which is Humira. It is not the drug I'm on, but it is very similar. And a lot of people with Crohn's, ulcerative colitis, arthritis, spondyloarthritis, like a lot of people some people with lupus, although it's less common for lupus, are on Humira. Next year, their patent expires, and there are 2 biosimilars that are under FDA review. And one of the big things that a lot of patient advocacy groups for conditions that a lot of patients rely on Humira is looking at is one of the tricks that insurance companies can do, which they make a lot of people on compound drugs, which are generally cheaper, utilize is if there is a generic available, they will not cover the brand name. But for some people, they find the brand name is not actually the same as the generic for them. We are going to see this even more with biosimilars because biosimilars are not the same ingredients the way a compound drug's generic might be. They have to be demonstrated in a clinical setting. And that is because the inputs to them, once again, economist, not a biologist, not like this is only what I understand from having to do research on this topic and being on the drug myself. But like here, there are two like big components. One of them is cells from Chinese hamster ovaries in my drug. And because it is a biological, meaning it has biological components, it comes from real living activated cells. That's one of the reasons you have to refrigerate biologicals. Because of those kind of choices, but because of that kind of production, I shouldn't call it a choice. I mean, I am still very grateful for my drug, which is why I spend so much energy trying to stay on it. But because of that component, it's more likely that a lot of people are going to need to stay on their brand name biological drug. However, their insurance company may try to say, we are not going to cover your mainstream biological drug. You have to be on the biosimilar. So a lot of things a lot of patient advocacy groups are looking at is how to make sure that you can advocate or appeal your insurance company if they try to switch you onto a biosimilar and it does not work for you. So one of the other reasons that the cost of biologicals has gone up so much in the US in the past couple years is that the US does not allow this type of synthetic test on injectables. All injectable medications have to be tested with horseshoe crab blood, which is this crazy blue blood. And it's very expensive, and they like force the horseshoe crabs to donate the blood by like hooking these alien like crabs like up to machines and then having like the blue blood come out of them, and then they release them back like 40 miles away into the ocean. Anyway, horseshoe crab blood, because it is needed to use to test injectable drugs, because it's used as part of this test in order to determine that you are not injecting like bad things. I think one of them being tetanus or something like that. I can't remember what it is, but it's great. It's a drug safety thing. However, a lot of other countries allow for a synthetic thing. We do not allow that in the United States, although there's been a lot of talk about it. And guess what happened in 2020? Well, the number of injectables, 2021, the number of injectables that need to be produced for the US and for the FDA approval went up dramatically because we were trying to produce a lot of vaccines. Because a lot of vaccines were getting produced, that put a cram on the supply chain for horseshoe crab blood, and the cost of the vials skyrocketed. Because of that is one of the primary inputs that goes into biologicals, which are usually given either by injection or infusion. And because of that did raise the cost. It is no excuse for the absolute highway robbery that is pharmaceutical companies' ridiculous costs. One last reason about why biologicals are so expensive is that the general research, and just to be clear, I do not excuse these prices, nor am I defending pharmaceutical companies. But there is a small explanation for why they cost so much more when they come onto the market, even when they're developed outside of the hellscape that is United States pharmaceutical costs. So one of the other reasons is the average cost of research and development in the pipeline for a compound drug generic is around about $1 million US. So that's how much it costs to, try to create a generic of an existing drug already. The average cost for the R&D for a biological medication is about $1 billion. So it's an order of magnitude higher. And that is because they can't just say, let's combine A, B, and C, and then we've got the compound drug. This has to be done through clinical trials. Obviously, there's live organisms involved in the creation of biologicals, and all of that is kind of a factor in why they're so expensive. Gene therapy is one of the new developments of one of the newer areas of medical medication development, and gene therapy has an even more expensive pipeline. So that's one of the reasons. Philip says, my monthly Nucala, I don't know how to pronounce their brand name, biological is also derived from hamster ovary stem cells. Only side effect is wanting to keep running on that little wheel. Well, that's the thing. You have to keep running on the little wheel in order to exist in the capitalist hellscape that is American health insurance. You got to keep running on the hamster wheel so that you can afford your drugs. Okay, sorry. Anyway, $800 to $12,000 for the same drug should be illegal. Agreed. So one of the reasons why it is not illegal, oh my God, sorry. Y'all, I do really want to give you like tangible advice, and I have stuff loaded on my thing here, but I love getting on these rants. One of the reasons why it is allowed, why there are no price caps on the United States for how much they can raise the cost of these drugs, is because autoimmune disorders were excluded from the essential health benefits in the Affordable Care Act. So because of that, we're not considered preventative. These aren't considered preventative drugs, even though they are literally preventing long-term disability and possibly death in many cases. Anyway, Aaron says, can I go to the pharmacy and bring you back some while I'm in London? Actually, I do not know what the cost without the NHS is. So it's £8 or whatever a month and then like less if you are buying it long term. Like they let you get a discount at the point of service if you're on the NHS. But it's unclear to me how you would buy it without the NHS. Interesting question. Abel Jack says, I like being special. Atabay says, wow, just wow. I mean, I told you I could tell you why they're so expensive. Malin says, this is so outrageous and embarrassing for the drug companies to be so abusive in their pricing. I am so sorry. Here's the only thing I will say about, the only thing I'll say about the pharmaceutical companies. One, I try to appreciate that. I really do appreciate that they developed this drug. Like, arthritis was actually one of the like leading causes of hospitalization for people with chronic illnesses before these biologicals came out. Like every hospital had beds for people with just arthritis pain. I could not hold a pen prior to getting on this drug. Like my hands wouldn't work. I had active arthritis for 8 years before I got treatment, which is once again the fault of the American healthcare hellscape. I appreciate the drug. I appreciate the research and development that went into it. I try to make myself feel slightly better by owning stock in the company that makes my drug. Not because I believe in their policies, but I feel like if they're making money off me, I should make some money off that. Eric says, higher unit pricing. Martin Shirelli, School of Marketing of Pharmaceuticals. I mean, they all do it. I mean, the thing, too, is, like, I don't want to get into too much of this, but, like, they're just trading patents. So, like, every one of these pharmaceutical companies that has an expiring biological patent, in addition to, like, fighting through the patent courts to, like, try to extend their patents, they all have in the pipeline a biosimilar for another pharmaceutical company's drugs. So they're just back and forth trading profits, And it's, like, it's frustrating because I think the thing that's, like, most upsetting to me, like, a great example is Trikafta, which is the brand name for a triple combination therapy that came out for cystic fibrosis. This is a life-changing medication that came out in the last 2 years in the United States. It's starting, it's being rolled out in a bunch of other countries as well. Cystic fibrosis is a genetic disease, and it is, the average person with cystic fibrosis, even a couple years ago had an average lifespan in their 20s. And the Trikafta is, the pipeline for cystic fibrosis drugs is hotly watched by people with cystic fibrosis because it really took a lot of technological advances and research in order to make those kind of drugs. And for a lot of people, it has been life-changing. You've got people that had life expectancies in their 20s. You had people that were on the lung transplant list that started Trikafta, and now they're planning for their retirement, that now have adopted babies and gotten off the lung transplant list. And Trikafta is effective for the genetic mutation of about 93% of people with cystic fibrosis. There's different gene mutations that are considered cystic fibrosis. And so not every single person with CF is helped by it. And there are also some people that it just doesn't work for other reasons. Perhaps their liver enzymes are one of the main effects of their CF. All of this to say that one of the things about cystic fibrosis is it is an incredibly rare disorder. And because of that, there is no amount of money that the drug companies could charge for this that would ever make them back their R&D costs, theoretically, because there just aren't enough patients. Under the FDA approval for this drug, it got what is called orphan designation, which essentially means like there ain't enough people with this. So... cool. Yeah, this is approved, but like we're not going to put any of these other kind of like cost limitations on you. The other thing too is because it is such a life-changing drug, it is a thing that most people can get approved by their insurance because they can demonstrate they have CF. If they have the right gene mutation, they can demonstrate that it is helpful for them. But it's hundreds of thousands of dollars a year, and it is also a maintenance drug. It is not a cure. So it is a thing you have to stay on. It's a thing where you're going to continue to have panels run on you because of the elevated liver enzymes, which is a risk for CF anyway. The end point of my rant, which required really a shocking amount of background on Trikafta, the thing about it is, it got this orphan designation, and they're allowed to charge hundreds of thousands of dollars a year for this drug that people will theoretically stay on for the rest of their life because it's a maintenance drug. And where did most of the funding for that research for Trikafta come from? The Cystic Fibrosis Foundation. Who is the main funders of the Cystic Fibrosis Foundation? Cystic fibrosis patients and families and friends that raise money for the CF Foundation. Additionally, who also donates to the CF, like, walks and fundraisers and things like that? The pharmaceutical companies. What do the pharmaceutical companies donate to the CF Foundation for? One, they advertise for marketing purposes because they need goodwill amongst the patients. Two, they donate because they get a write-off on their taxes. So my question is, why do we allow this publicly funded research, this research that's funded by the patients who are going to take the drug? Why do we allow this kind of profiteering based on the idea that they won't be able to recover their R&D costs? They may have already gotten the write-off for those R&D costs. Two, R&D is already something that they deduct on their overall costs. So why do we allow that highway robbery costs? Which is, just to be clear, it is beyond the costs of production for these drugs. They are making money off these drugs once they come out. And yes, few people are going to take it overall. Probably on paper, their R&D costs will never be recovered. But we do have an interest in having people live longer and not having children die when there is a medication on the market for them. And so the question is, why are they allowed to do that? Because in the end, who actually ends up paying for that? Well, all of us, because it is paid for by Medicare, Medicaid, CHIP, depending on that, or paid for by the insurance companies, and that's part of the risk pool that we are all part of. So why are they allowed to charge so much for their own profits? Okay, sorry. Atabay says, genius, you leave me with homework once again, lol. I'm sorry, I don't know what that was referring to, but I love leaving people with homework. Philip says, I do appreciate the pricey shot I get each month. Only other alternative is continued high doses of prednisone steroids, and I'm enjoying breathing. I'm so happy it works for you. I try to come back around to gratitude. Like, someone worked really hard to do the research to give me this drug that gives me, like, I can hold a pen now. I was on track to likely be disabled before retirement age. And now I had rapidly degrading joints. I may have ended up needing to use a mobility device to get around, and I am able to figure skate now. And that very much comes down to my access to the biological drug. So I try to lead with gratefulness, even though I also am very angry at the system. And yes, I don't like prednisone. I like that it works, but it has, obviously, like all steroids, has really high side effects. I like to call prednisone the rearrange my furniture in the middle of the night steroid. I only have to be on prednisone when I have flare-ups now, and I try to get on and off of it very quickly and do my taper very fast because I don't like the side effects. Obviously, there's more side effects than just rearranging my furniture, but also the increased appetite is wild. Eric has a great comparison here. My father had to be on prednisone due to autoimmune, and it's miraculous, but it's like running a car on nitrous oxide and methanol. Not a long-term good thing. Absolutely. That is a great description. And you can have adrenal failure if you're on it too long. A lot of people are on prednisone for like ever. It is a wonder drug for short term. I agree. Eric says every time he was on prednisone, it was followed by weeks / a whole month of tapering off. Yeah, I mean, and you have to taper, right? Because otherwise you're really going to fuck up your body. Philip says prednisone only worked for about 2 weeks for me at a time. This nucleus shot once a month works better, no side effects. Amazing. Turns you into a gremlin. I love it. Okay. Y'all, I do want to talk a little bit about the things that you should know when it comes to health insurance. So I described the EPO and the PPO. Does anybody want some descriptions of the difference between a deductible, your premium, your copay, and your co-insurance? It seems like we have a very healthcare knowledgeable crowd in here. But I'm going to talk about like how to find your different options for coverage here. Oh my God, I hope that the Apple TV is on. Let's find out. Is it on? Oh, no. Oh, there we go. Good. All right. There we go. Cool. All right. So what I'm going to do is try to walk you through what my options were. So there are, like I mentioned, there are a couple different ways that you can access health insurance if you're above the poverty level in the US. And one of the main one that they always want you to start with is through your employer. So as long as the premiums cost you less than 9.12% of 9.12% of your household adjusted income, you are going to need to go with your employer or your spouse's employer plan. In my case, my spouse has coverage through his workplace, and because of that, I am able to be covered on it. The downside is that I am now just limited to the options. I have more options if I go onto the marketplace, which is where I got my health insurance before we got married. And, I guess immediately before that, I got it through my employer. But it means that I'm limited to only the options from their employer. So this is one of the options available, and this is kind of what you might see if you go through your employer. They will likely give you an option they will show you like a little kind of comparison chart, and they'll be like, okay, if you get the EPO, the PPO, or the HDHP plus HSA. So what is an HDHP? An HDHP is a high deductible health plan, and the advantage of an HDHP are twofold. One, you will likely have a lower premium. If you go through your employer, it's quite likely they may even make it a $0 premium for you, so you don't have to pay anything out of your own monthly premium. But at the very least, it will be lower probably than the other options that have a higher deductible. To be an HDHP, they have to be the deductible has to be $9,100 for individual to qualify as an HSA HDHP. What is an HSA? Well, an HSA is a health savings account. It is not the same as an FSA, which is a flexible spending account. The reason why this is important is that an HSA is money that you get to keep. It is your money. If your employer really wants you to choose a high deductible plan because it costs less for them, they might put money in a health savings account for you, but that is your money and you get to keep it. And it is triple taxed advantaged. So it is before tax when it gets put into the HSA, and it is tax-free when you take it out. So as long as you take it out for medical expenses. And the advantage too is that you could You could, pay for medical expenses out of pocket now, but continue to put money in that HSA account each year, and maybe your employer also puts some free money in there for you. It is yours to keep. It does not stay with the employer. So even if you leave that employer, that is your account and it is for you. And you can also set up one on your own if you're getting an HDHP through the exchange or on your own. But that HSA, a bunch of them allow you to invest that money. So with compound interest, you can actually, have that invested as long as you're over a certain amount and keep putting that money in there, and then later take that money out if you have a large medical expense or if you save your receipts for medical expenses. So it can be another way to save tax-advantaged money, and it also converts to a regular retirement account once you hit retirement age. But a recent study found that over the course of their lifetime, American couples spend $300,000 on out-of-pocket expenses for medical expenses. So, because America's great. Anyway, because there is such a high expectation that at some point you will have out-of-pocket medical expenses, you will be able to save that HSA money. Okay, so that is an advantage of the HDHP. However, your deductible might be quite high. The generally HDHP plans are best for someone that usually is in one of these two situations. One, they use almost no medical expenses and they have the cash flow that they could pay out of pocket for certain things. However, please note, if this is an ACA plan, a lot of your preventative services like vaccines and stuff like that, you will not have to pay out of pocket, even if you have a high deductible plan. So certain kinds of labs and tests and a preventative care visit at your doctor. Here is the thing to know though. If you get coded for any other kind of visit at that preventative care, then it's not going to be covered. So like, let's say you go in for an annual OBGYN exam that is covered as preventative care, but then while you are there, they're like, oh, I noticed you have this weird rash on your leg. I noticed when you were up in the stirrups. And they prescribe you a medication for this rash. Well, then all of a sudden that entire appointment may end up not covered because it is gotten coded as treatment that is not preventative treatment. It is treating an exact illness. So it is a thing to know. And it is also a way that you can advocate for yourself if you think that something should be covered as preventative, but then it got coded incorrectly. You can call up the doctor's office, the provider, and be like, hello, this got coded incorrectly. Okay, so this is an HDHP that has an actual HSA. Here is a thing to understand about the deductibles here and the out-of-pocket maximums here. Notice that there is a different network and out-of-network deductible, and that is a thing they are absolutely allowed to do. And if you are getting in-network coverage, this is not actually just $800 more. Even if you have met your in-network deductible, this is an entirely separate deductible under most plans. So the thing to know is you might be looking at a combined amount if you expect to access both in-network and out-of-network coverage. So if you have very low cost and you can cover something out of pocket and the only thing you expect to need is some routine preventative stuff, then a HDHP can be a great option for you, especially if you want access to that health savings account to use as kind of like an extra retirement account or just plan ahead for the future. It can be very good for people with high taxable incomes because it gives them an opportunity to have another tax advantage space to max out. And your employer might actually put some extra money in there for you in the HSA. The other group of people for which this used to be really effective prior to copay accumulators going into place more and more in the past year, and I used to be in this category, are people for which they actually have high healthcare expenses, but most of those healthcare expenses are covered by a program like a patient assistance program. So in my case, I would have a high deductible plan and my deductible might be $7,000. However, I would meet that deductible and my out-of-pocket out-of-pocket maximum was also $7,000, I would meet that not using my own money in January. And that meant I had a lower monthly premium because I had a high deductible plan. But I also didn't have to pay for any of my medical costs as long as they were in network after January, because I received copay assistance from the manufacturer of my drug that counted towards my out-of-pocket maximum. And it also counted towards my deductible. However, with the implementation of the July 2021 HSS rule about copay accumulators, which I've talked about on 2 or 3 previous live streams because I got screwed by it this year, no longer does the debit card that I use, that I am provided by the manufacturer of my drug as copay assistance, it no longer counts towards my deductible. And because of that, I ended up having to pay for lots of things this year, which I was not happy about. So, that it used to be that a lot of people were in that category. Here's the thing, is that copay accumulators are banned in 13 states and Puerto Rico. However, they aren't banned in mine because the health insurance lobby is big, and they are not banned at the federal level, which means that they are not banned if you are on an employer plan that is a self-insured plan. So if you work for a large employer and you're on an employer plan, then they're not banned under federal guidelines, which means that about 50% of people could be affected by copay accumulators, and they're getting more and more implemented. So it is a thing to be aware of. If you are, is it banned in Texas? I sincerely doubt it, but we can find out for you. Let's find out right now. There is a little, okay, copay accumulator ban. So I will talk very quickly about how to tell if a copay accumulator is in place. If you are someone that gets pharmaceutical assistance to purchase your drugs, which pretty much anybody on an expensive states banned. Okay, let's find out. It's 14 states now because there's a new one. It's way more than 10% of. Okay, no, Texas is not banning it. Oregon will never ban it. And also, if you're on an employer plan, it doesn't matter anyway, because your plan is regulated at the federal level and not at the state level. So I just qualified for copay assistance, so this is all good info. Okay, good. Okay, so let me tell you about how to research if a copay accumulator is in place for you. So I will link to this in the show notes as well. But if you go to Arm and a Leg Show, you can find a podcast. There's a transcript as well. That is an interview with me with Dan Weissman, who hosts the Arm and a Leg Show, which is a lovely radio show about the cost of healthcare in the United States. And he talked about the copay accumulator situation that I found myself in, which is that I unexpectedly owed a $3,000 copay that I didn't think I was going to have to owe because I was using copay assistance. So I had done all of the research to see if a copay accumulator was in place during open enrollment last year. And what I ended up doing, one, I went and I called I tried to call the healthcare plan company. I called their specialty pharmacy. I called member services. I asked them about whether or not it was in place. Here's the thing. There's no regulation that says that they can't implement it mid-plan year, unfortunately. So I was affected by a mid-plan year implementation of a copay accumulator. So it didn't even matter that I had done all of this research. But the AIDS Institute did a huge study looking at copay accumulator and whether or not they are in place on plans. And they're researchers who were funded, once again, by a drug company because the drug companies are invested in these copay accumulators because they prop up their prices in a monopoly market. It's all terrible. The AIDS Institute's researchers made this tip sheet about how to try to find if your plan has a copay accumulator. So if you go on healthcare.gov or whatever your state exchange is, you should be able to find the plans available to you in your area. If you are getting it through employer, look through the plan documents that are provided in your portal or wherever your employer puts them. If you work at Facebook, then it'll be in the metaverse. Anyway, you can look for the summary of benefits and coverage, evidence of coverage, certificate of coverage, plan policy, or plan contract. They all have different names. For me, it was evidence of coverage. Within the plan document, use the Control F function and look for these words like manufacturer, copay card, coupon, or copay assistance. What you need to find out is if manufacturer assistance will be contributed towards a deductible. If you look for these words, it's most likely because it's saying that they do have a copay accumulator program in place, and those copay accumulator programs are means that they are going to have something that says that that will not apply towards your deductible or your out-of-pocket maximum. In which case, even if you still qualify for the pharmaceutical assistance, you need to make your decision as though none of those dollars are going to contribute towards your out-of-pocket maximum. The other thing to know is that it used to be that these pharmaceutical companies, like copay assistance plans for patients, were the annual limit is essentially based on whatever the annual out-of-pocket maximum would be. So for me, it would be like they will pay up to $12,000 a year on my behalf. And they, my out-of-pocket maximum was $7,000 because at the time that was the federal limit. And because of that, there was a limit on how much the manufacturer would have to pay on my behalf. And then all of my expenses for the rest of the year would be covered. Like, for example, one of the years that I broke this wrist, I've broken both my wrists, but one of the years I broke this wrist, this was like $26,000 worth of expenses, but I'd already hit my out-of-pocket maximum in January, and I broke this in July. And because of that, I didn't have to pay anything as long as no one out of network touched me, which was my big paranoia. Going into surgery, I was like, anesthesiologist, you are in network, right? Anyway, so if you cannot find anything in the plan documents, you have to try to call. And this is one of the things that they say you can follow up with a customer service representative. I spent about 45 minutes on the phone with Kaiser 2 weeks ago trying to get information just about how much my copay would be for my drug, because I know that it won't let me use it won't even let me use copay manufacturer assistance cards, and they couldn't tell me how much a drug would be on their plan at their pharmacy. So we're doing great. But you can try to call them. You may end up in a phone chain. It's very frustrating, but that is one of the ways to look. They do technically have to disclose that it's in place to you, but not until you're already enrolled in the plan. So yeah. Malin says, U.S. healthcare patient policy abuse is raising my blood pressure. I wonder how much drugs for this insurance-induced malady is going to cost me. So frustrating. Yes, I know. It's super frustrating. And the reason it's super frustrating is because it's gambling. That's what's really frustrating to me. So as someone who went to school for economics, my least favorite class was game theory because I hate gambling. I like certain risks. And most people like to have an idea of what the downside of a risk is going to be for them. But one of the problems with American healthcare is because the costs are so inflated and there's so much arbitrary randomness in the system that my blood pressure went up so much just trying to choose between two different plans and two different insurers a week and a half ago, because it's gambling. The question is are you what's the risk if you how much might you possibly end up needing to pay if you get have a major medical event? The fact that in America, a birth, the average birth costs $7,000 out of pocket, that kind of thing is just such an annoying gamble. The fact that they get to choose who the primary coverage is for your kid based on which parent's birthday is earlier in the year, it's just gambling, and it's a rigged, stacked deck. Speaking of frustrations and angriness, I think it's time for a break for Flu for the Week. Let's try not to have our blood pressure too raised, but Here is our adorable floof of the week, who looks a lot like Dora, but in fact is a different floof. So, floof of the week is patrons, people that support Oh My Dollar on Patreon as part of the Personal Finance Society, which you can find at ohmydollar.com/support. They can submit their favorite floofs, or sometimes even scalies, and we get a look at them and appreciate just how cute they are. This kitty's name is Elder Kitty, and this is Rural's kitty from the Oh My Dollar forums. And Elder Kitty likes napping and talking to the dogs, Raptor and Pickle, from a safe distance. She's also fond of fuzzy pillows and throw blankets. She is 16 years young. Look at this floof. Look at that face. But it looks kind of like Dora. Speaking of floof-related Dora content, right before this live stream, she woke up from her very long nap. And look at this quality video of Dora being extra. I emptied the recycling bin in the office, and she decided that it's like her new best friend and that she needed to break into it. This is 40 seconds of quality content right here. Oh, and then she got distracted because there's drawers, but then she realized she needed to go back to this. Right after I stopped filming, she ended up tipping it over. Anyway, there's your floof content. Look at all the floofness. David says, don't let your blood pressure rage too much. They prescribe things for that. I got named as a concern for high blood pressure because my doctor would ask me about work every time he took it. Yeah, I always end up in this long discussion with the rheumatologist about healthcare and what a hellscape it is, and I feel like my blood pressure is higher. Is it time to do the donut? Should we do the donut before we dive into? I do want to actually, I have pulled up, I figured we could go through like what it looks like on healthcare.gov and a couple of the things like how to look to see if your medication and your provider is covered, understanding the formulary, and then I can kind of walk you through like the decision-making process I was making if you want. I do realize that this has turned into more of a rant than a useful live stream, and I hoped for it to be useful. So I would like it to be useful. Last year during Healthcare Month, we actually like had a couple people that told us like their income and their zip code, and we actually went and tried to like look up plans for them in the health insurance marketplace, which could be useful. I also put together like a dummy profile. So either way, we can do it. And I do want to share this lovely calculator that you can use. So there is a great calculator. I will put the link down below. The link down below here, that is the Kaiser Family Foundation Health Insurance Marketplace Calculator. And this is updated for 2023. So what it will tell you is that you would put in your state. So like, let me put in Oregon. The big frustration for a lot of people is that like you have to fill in a whole application on healthcare.gov if you want to see how much the subsidies are. And that can be really frustrating, especially if you're like trying to decide, like maybe you want to use a different zip code or something like that. But this will help you calculate out what your subsidies will be without having to go through that. So we'll just use like a sample zip code here and my state of Oregon. And then we'll say my annual income is $40,000. And let's say I don't have coverage from my spouse or employer job, and that it's one person and there's one adult, and let's say the age is 40 and non-tobacco user and no children. So $40,000 for a single person would be equal to 294. Did I type in 40,000? Yeah. 40,000 would be 294% of the poverty level, which means that I would be eligible for subsidies, but I would not be eligible necessarily for some of the cost sharing provisions. So essentially I would get $232 per month to apply towards a plan. And so this is how much it would cost me for premiums if I was to get a silver level plan. I'm also happy to walk through what the different costs are or what the different like tiers are between gold, silver, and bronze plans so that you can kind of get an idea of what they might cover. If your household income is below 150% of the federal poverty level, which is for a single person, $20,385 for a single person family, and $41,625 for a 4-person family. So if you are low income, but not so low income that you qualify for Medicaid in your state, then you will essentially get free healthcare coverage, and also you will get subsidies towards they're essentially cost sharing reductions. And so that means they'll help you pay for things like your medications or your copays for visits. However, you have to select a silver level plan. And the reason this is important is because if you select a bronze level plan, you actually are not going to get that extra cost sharing, and there's no reason to not select the silver level plan. It's going to end up saving you money and be better coverage for you. You could also select a bronze level plan, even if you are at that between 100 and 150% of the poverty level. And that means that so if you get a gold level plan, it means that you're still going to get those cost sharing provisions, but you may have to pay a little bit out of pocket for that like nicer level plan. Okay. Your info and strategies are very helpful. I'm glad. I'm really glad that they are helpful because I do feel like I'm just kind of ranting. I do want to make sure that people understand all of the terms that I'm throwing around, but obviously, like, it's a lot to explain all of health insurance at once. I should probably do an edited video that's like a little more to the point, but I get so overwhelmed dealing with all of this. Your approach is reassuring. Well, I mean, I absolutely had like a meltdown trying to choose my own insurance. So I'm just trying to make it better for everyone else. Aaron says, I want to pay my bill and get out of here and go sit in a different bar. Gosh, I sound like the cat. You're having some slow service. So I'm glad. When you first said you had slow service, I thought you meant you had slow internet. And I was like, why are you watching a live stream? Newbold One says, I honestly, truly, and absolutely do not understand how you all survive this distressing level of complexity. One, the answer is we do not all survive. Like, literally, people die because of how broken American health insurance is. People die from lack of coverage. People die from how long they have to put off getting procedures, getting preventative screenings. Like, we have literally the data on it. People die. We have a way higher maternal mortality rate than any developed country in the world. We have a higher infant mortality rate than any developed country in the world. The answer, how do we survive handling this complexity? We don't all survive it because it is absolutely broken and shameful in the richest country in the world, how broken American healthcare is. And that was my soapbox. But like, the answer is we don't all survive it. And yes, we do all need to be lawyers. It is heartbreaking. Geograph Concept says, I haven't even missed the donut. Yes, that's because the topic is healthcare. So we all have ended up, I've gone off a few times. Wow, I get Taco Bell and the stream is still happening. Have I been going for oh my God, it's already 1. I'm sorry, guys. It's donut time. Let's eat the donut. And then I will drop all the links about how to like search for your coverage costs. And if you want me to do a sample, or actually decide. Do you want me to do a sample of showing you how to like look things up on healthcare.gov, or do you want me to compare between the two different options I had for the employer plan and how I tried to figure out if my drug was covered and how much it was going to cost me and what options I weighed between the two? So let me know, and I think it is donut time because it's 1 p.m. already. I'm cracking up. It's already 1 p.m., y'all. Okay, so the donut today is a passion fruit and lime situation. Oh my God, I almost lost it. Well, if there's a finger stick in it now, it's because I did a bad job. There we go. I was trying to get it focused. It's passion fruit and lime, and it's like lime sugar on the top. There are all new flavors again, so I'm really excited. Okay. Donut. Time flies when having fun. Time also flies when you're upset and having a continual existential crisis about American healthcare. All right. Oh gosh. Okay. It's pretty much a Sour Patch Kid in donut form. Which sour candies are like far and away my favorite candies. It's pretty much a Sour Patch Kid because like there's like sugar on the top, but it's lime sugar. And so it's kind of like the citric acid coating on Sour Patch Kids. It's really good. All right, we had 2 votes for option 2, which is where I'll walk you through my own decision making. If anybody wants to vote for option 1, which is where I will look at the health insurance marketplace and kind of show you where things are and like how to look up providers, put your vote in now. It's pretty much a Sour Patch Kid. Yeah, I'm really liking this. I'm not usually a huge fan of passion fruit, but I'm really liking this. It's absolutely delicious. Okay, I have put in the chat, and I'll put in the description, the subsidy calculator. So that allows you to make kind of like a guesstimate. Yeah, it's actually like it's more doughy than it is cakey on the inside, actually, geograph concept. It's sort of like it's like a doughy, fluffy donut. But it's not like a cake donut, it's like a proper donut. Oh, Eric wants to do an estimate of how much I'm gonna rate it. I'm thinking I'm gonna say 4 out of 5. It's because of the sourness. Honestly, if it was just a plain donut coated in that lime sugar situation, I would be on board. It's so good. Yeah, 4 out of 5. All right. Anybody voting for option 1? I didn't bring in a napkin, so I just have to clean my hands on here. Malin says, poor Aaron is probably stuck eating some British culinary delicacies such as rumpled the thumps. We're allowed to make fun of the British because colonialism. Here's what I have to say. You're in London. Don't eat any British food in London. I will say I would love it if Aaron, especially because Aaron's on per diem for work right now. One of my favorite restaurants in London is called Dishoom. And they have like a vegetarian full English breakfast, but like with the flavors of Indian cuisine. So full English breakfast, I think, is like the only thing they do well. Like, I cannot understand how they grill half a tomato and it's good. But they have a lot of things that I just feel like are very bland, but especially when combined with Indian cuisine, Dishoom is like kind of pricey, so I don't go there very often. There's another place, not actually far from that's like along the East London like high streets, and that place is like an organic restaurant, but they have like a vegan full English breakfast. It's once again, it's all London prices, so it's like £20 for breakfast or something like that. But it is a full English, so it takes like an hour to eat. Yeah, it's really good. That's about the only thing I can say. Oh, and although maybe this isn't true anymore now that they're out of the EU, but my favorite part of candies in the UK is that the EU has the vegan versions of, God, what is it called? The German gummy bears. What is the German brand? Haribo. So they have the vegetarian and vegan versions of Haribo available, which are not sold in the US. Haribo's like, there's only like 1 or 2 flavors that you can even find in the US usually, unless you go to like some specialty import store. But they have vegan Haribo, and as someone who really likes gummy candy, and it is hard to find gummy bears that are vegan in the US, I do like importing a bunch of those when I come home. I think Aaron's actually going to bring home Daners, though, as long as he can import it, which is, I think, a much better version of like Dayquil. I think it's like infinitely better. I like Day Nurse and Night Nurse, and neither of them are available here in the US. And so I always try to like import them. Also in my state, up until last year, you couldn't even get regular like Dayquil because without a doctor's prescription, even though it's over the counter in every other state, almost every other state, it was considered under the counter, which meant that you had to pay to like go get a doctor to write you a prescription to get it when you just had like a regular cold and you wanted some Dayquil or NyQuil so you could sleep. And that's because we have a methamphetamine problem in my state. But, you know, where doesn't have a methamphetamine problem? And we're, you know, we've a very blue legislature who loves to regulate the crap out of stuff. But that now you can get it. But here's the thing I learned. In addition to having to pay, which I had to pay for like a telemedicine appointment in order to like get them to write me a prescription to be like, you're not going to go make meth in your bathtub with this Dayquil. It was not covered by my insurance because they classify it as an over-the-counter medication. So despite the fact that I had met my out-of-pocket maximum, that I had to like pay to go see a provider, it was not covered the way other medications would be because the insurance company said in every other state, this is an over-the-counter medication, even though it wasn't an over-the-counter medication in my state. So fun health insurance problems. Day nurse and night nurse, they're so good. Philip says, but remember to buy a plane ticket for what you're bringing home. Day nurse. Aaron kept saying day nurse, and I could not figure out what he was saying. Anyway, grilled tomatoes and beans on toast. I do agree, beans on toast is pretty good. As someone who also crumpets, excellent in the crumpet department. Atabay says, thankfully I had some voodoo donuts here. Lol. See, this is my feeling about voodoo donuts. This is what I come entitled to it as a Portlander. One, they suck to work for. They actually like got fired, like the National Labor Relation Boards found against them for retaliation after their workers tried to unionize and unsafe working conditions because they fired workers who refused to work when it was 115 degrees outside in an unair conditioned donut kitchen. They fired workers who said that we can't work in these conditions, it's unsafe. Those workers happen to be the union organizers who had just voted to unionize their stores. So it sucks to work for them from that perspective. And almost everybody in Portland that was like a crust punk of a certain age who lived in Portland knew someone who worked for Voodoo. And the last thing I'm obligated to say as a Portlander is that Voodoo Donuts are for tourists. And we have better options here. Sorry. I have feelings. Beans on toast with extra Marmite. Marmite is also quite good. Aaron says, I asked if I should bring home Daners, and Lily kept saying, what is Daners? And looking at me like I was speaking a different language. I thought you were, like, mispronouncing donor. I was like, why would you bring donor home from London? It's not good there. And also, how would you bring it home? Adame says, it's all the craze in Houston. We have nothing like this, but wow, I had no idea of that. I mean, so here's the thing, like the guy who started it is like, he's a big donor to a lot of nonprofits. So like everybody in Portland that works in nonprofits knows him. I appreciate that they're doing rapid expansion. I'm not sure like how on board I am with their like cultural appropriation of voodoo culture. Especially now that they're expanding to like states with like a higher group of people that come from places where voodoo is actually like practiced. But the main thing is just like everybody knows voodoo here, but it's like the thing that all the tourists do. There used to be like line around the block because it used to be only just this one. It also was like the last place that was cash only in Portland. Like it was still cash only like in 2020. But also they like didn't really have recipes for a long time. And yeah, I had friends play a show there above the bathroom, which, cause like there was no stage. It used to be really tiny before anyway, I have all the voodoo facts. The lines can be crazy. The lines are not crazy at voodoo anymore here in Portland, I would say. New World One says Lost in Translation, the British English edition. As they say, two countries separated by a common language. I mean, I don't really think this is about a common language. I think it was just about me not understanding what Aaron said. Because those are both words pronounced the same in English. All right, it seems like people want me to go through option 2. We can also close out. If you're done talking about the stress that is American health insurance, that's fine. We have all month. But for a lot of people, their open enrollment will close probably next week at their employer. Like a ton of people, open enrollment is the 1st through the 15th. Some people, open enrollment is only like 2 days long, which I think should be highway robbery. Some people have already had it. It's open through December 15th on the healthcare marketplace. I can talk more about some of the expansions that have happened this year, or we can just puzzle through my own personal hellscape as someone that's on an expensive medication. And trying to figure out which plan to go through. Adabase says, you have all the inside scoop, love it. I mean, if there's anything you need to know about a Portland small business that donates to local nonprofits, I probably know it because there were only like 5 jobs in Portland for a really long time because we have a crappy economy, so we all did the same jobs. We all worked for like McMinimans, Voodoo Donuts, like the New Seasons. Anyway. Or health insurance companies or healthcare, because it is one of our largest industries. Intel, Nike, and Kaiser pretty much propping up our state's economy. Because we don't have any timber anymore. Okay. So what we can do is we can walk through this. Who wants to vote for me to just be being done? Like, I'm sure you all have like things to do in your life. So we can look through plans and pricing if we want. I actually applied for copay assistance thanks to one of your old videos. I'm so happy to hear that is like a thing. I'm so happy to hear that anyone benefited from my rants on health insurance and got access to any sort of coverage. So thank you. That makes me feel really good, because mostly it's just me spewing my frustrations out on the internet. Hopefully, if this book happens that I'm co-authoring, if this book happens someday, my rantings about health insurance will hopefully help thousands of people. But mostly I think it's just me having an existential crisis. So I have told my husband I'm here for a good long time, not long after I saw the prices. But now I have hope. Oh, okay. Well, that's good. I'm very, very happy to hear that. Okay, should we talk about, how about I talk about like what I went through when it came to choosing my own coverage here. So, the options that we had through the employer, there was a couple different options. The coverage was for both me and my spouse, and because of that, that meant the premiums were much higher, because when you cover a dependent, usually they're higher, right? So one of the options that we could have, I did one that hid the employer on here, since we don't need to share that with everybody. But this is an example of like what this would look like. So under this option, this is a employer plan, and this is the HMO, and I believe it was Kaiser. So the big thing was that, like, from the get-go, every single state had different regulations about how much it was going to cost. And so you had to actually find your state on the top. So when it came to this, you know, like I said, a lot of these are regulated at the state level. Even though this is a federal employer plan, there are still some state restrictions that can happen on them. And so this was the maximum out of pocket. So this is the maximum that you could pay, $1,500 for an individual, and $3,000 for a family member. And it is what is called an embedded deductible. So an embedded deductible embedded out-of-pocket maximum means that your deductible can count towards it. Embedded deductibles are usually what you would want to prefer. If you don't have an embedded deductible, then that means that sometimes you have to meet a deductible and then the out-of-pocket maximum can start again, which is crap. So in this case, this was an option where I would have to pay for the, I believe this was, hold on, let me check. So this is the HMO. So this was Kaiser. And the big advantage here was that there was no deductible. So I wasn't going to have to pay anything like in order before it sort of kicked in. And this was one of the big downsides this year. My deductible was, I think, $4,250 because we chose a high deductible plan. But unfortunately, as I mentioned, my copay assistance had a copay accumulator kick in, and because of that, I ended up having to pay for things I didn't expect that I was going to have to pay for, because I thought I would hit that deductible very quickly. So no deductible on this plan, but it would cost $450 a month for the two of us. For two people, $450 a month, it's not crazy high. It's not very cheap. But you know, it's like a third of our rent on a 2-bedroom apartment. Almost, no, a quarter of our rent on a 2-bedroom apartment, which is, considering housing costs these days, not great. So not great, but look at how low, so no deductible means that the only thing I need to worry about now is how much are my routine things going to cost me. So when you're evaluating plans, you need to have some idea of what you expect your routine medical costs to cost you. And then the other thing you want to consider is what the worst case scenario is. So in my case, The worst case scenario is also kind of my routine expenses because my drug is so expensive in so many ways. But generally, the worst case scenario would be like, so let's say, for example, you expect to give birth during the next year. One of the things you should look into is what your worst case scenario is, which means like, what if you end up having to go to an out of network hospital? What if your provider is out of network? What if your anesthesiologist and you have to get a C-section is out of network? Like, look into what it is going to cost you in the worst case scenario. Maybe your worst case scenario is you have a major medical event that you don't expect, and like, what would that cost? Like, if you break a limb or something like that and you need surgery, okay, what would that out-of-pocket maximum be? So that is the kind of thing that you need to like clear that between there. Once you hit your out-of-pocket max, you still pay your normal copays, right? No. So if you hit your out-of-pocket maximum, that is the most that you can be charged for in-network services. So it is, if it's embedded, that means that whatever you pay towards your copays and your deductible will count towards that out-of-pocket maximum, and then you will be on the hook for $0 after that. So that is one of the things where if you are someone that is going to see a lot of providers, if you have to get a lot of regular things that are going to be covered but are going to cost you. So a great example is physical therapy or occupational therapy. You're going to a frick ton of appointments, and each of those appointments is going to come with a specialist fee because it is going to be billed. In my case, it's billed as an outpatient hospital visit because the only covered provider for me is within like, the hospital campus. And so it's considered outpatient hospital. So it bills at an extremely high rate, and I have to pay every time I go to that PT and that OT. So if you're someone that does have high medical expenses, having a low out-of-pocket maximum or deductible plan, as long as you know that that stuff is going to be in-network and covered services, you may find that you save a lot of money. And all you really need to do is to run the numbers. If you have predictable medical expenses, is look at how much the copays would be, look at what your out-of-pocket maximum would be, and then add together how much you would be paying in premiums. So let's say you've got an employer plan and it's going to cost you $100 a month in premiums. A good deal, but let's say your employer covers a bunch of it. So let's say you're going to be only paying $1,200 this year in premiums. So that's $100 times 12. Then additionally, you are going to pay, like, here's the great thing. You've got a primary care physician that you're going to need to see at least once to get a referral to your specialist. And then you've got a $20 per visit to your specialist. So let's say you need to see the specialist 20 times, 3 times a year. So that's $60. And then you're going to need to see your primary care physician twice a year, let's say. So that's $40. Now, here's the thing for this. Now, let's say that you're going to need PT, OT, or ST. One thing to do is to look in your plan documents and see if there's a limit, because some plans will limit you to 10 PT appointments per year, which could go away very quickly if you, like, for example, have a major medical situation and you need a lot of PT after it. If you're someone that needs regular occupational therapy because you have crap hands like me or something like that, then those 10 visits could go very quickly. Some let you have 50. Like, it's, there's a totally different amount on the limits. So that's a thing to check in your evidence of coverage or your plan documents, whatever they are. So right now we have $40 spent on the primary care visits. And then we think, $60 on specialist visits. So we've got 5 doctor's appointments that year and $100 of costs there. And then we've got $1,200 in premium costs. But now the big thing that we're looking at is we're like, oh no, I'm on a specialty drug. If you're on one of these high cost drugs, like a gene therapy drug, most types of chemo drugs, or biologicals that are used to treat anything that you get like as an infusion, anything expensive like that, it'll usually be classified as a specialty drug. If you look on your insurance, you will be able to see what kind of tier that is. And the place where you would look is called the formulary. here is the fun thing, though, that I discovered when I was doing research on this plan. So I was like, okay, here's the formulary. The formulary is this massive hundreds of page document usually that will tell you what kind of tier or evaluation is. Often the tiers will be described as 1, 2, 3, 4. Sometimes it'll be 1, 2, 3, 4, and then specialty. Sometimes it'll be 1, 2, 3, 4, 5, and 5 will be the specialty tier. And sometimes they'll be like on this HMO, they're listed as either generic or specialty, or is there a third one? Yeah, just generic and specialty. So here was the thing that really scared me, because I've had Kaiser before and I knew that my drug was able to be covered. However, I went in looking for my drug. Intracept is the generic, like the medical name of my drug. Enbrel is the name when it comes to, how do you control F on an iPad, y'all? It's an interesting question. If I tell it that I I don't know how to do this because I don't know how to make the keyboard come up, y'all. Okay, so I am going through here and I want to try to find I don't know how to control F, you guys. Does anybody smarter than me know how to control F? So usually what you do, share button, find on page. Oh my God. Geograph concept. I thought you were going to be the one that was going to help me. Thank you. So here was what was scary to me. I searched for Enbrel because, like I said, there's no biosimilar yet. So Enbrel should make it turn up. No matches. Then I looked for Intracept. And I was like, what the heck? And it is not anywhere. No matches. And I was like, oh no, my drug isn't covered on the formulary. But I had Kaiser before and I got on this drug originally. So what I found out, because I was like, there's no way that they can't cover this even as a specialty drug, because this is a first line treatment for arthritis. I was on it before. They can't just like straight up not cover this because there isn't an alternative really. And I also couldn't find Humira, which is another specialty drug that is, like I said, the biosimilar is probably going to be approved sometime next year. And it's going to, I'll definitely do a live stream talking about like the shockwaves we expect that to send through the American healthcare system, but maybe not, because they just have figured out, they've been planning for it for 20 years. What I found out, I was like, oh my God, what are you talking about? Why can't I find this? Then I found out they have a separate formulary for specialty drugs, which is a thing I'd never encountered before. But they have a whole freaking specialty formulary for the drug that is listed in it. I had to go find it on their website. It has nothing to do with it, and I got almost a freaking heart attack that I couldn't find it, because I was like, there's no way that this isn't covered. So that is what you normally do. You look on the formulary. If you cannot the formulary has to be published under law. It has to be published for all ACA compliant plans. So if you can't find it through your employer portal, on healthcare.gov, the formulary should be directly linked. But if you cannot find it, search for the name of the plan. So it'll have like a legal name. So it might be like Kaiser HMO 750 or something like that. And on the insurer's page, you should be able to find the formulary. It'll be this massively long PDF. And look, if your drug is a specialty drug, or, you haven't had it before, it might be like a searchable page where you're actually able to like type in the name of the drug and like the dosage. But if it isn't one of those, then what you can do is you can, you may have to look and see if there's a separate specialty formulary, which also, like, I've been navigating the world of specialty drug formularies for 8 years, and this is the first time I've ever discovered a separate formulary for specialty drugs, and I was very unhappy about it. So let's see, is it on this one? Because I didn't bring it up, of course. 1,000+ matches. There we go. Okay, so this is a lovely, great example of how terribly frustrating a formulary No link to the specialty formulary from the regular drug list. Smooth move. Yeah, I know. Real great, right? Okay, so this is kind of what a formulary will look like. I am actually, it's really uncommon for me to find them where they only list the drugs by their brand names, because usually you'll see like the brand name, comma, whatever the like, I don't want to say generic name, but the medical name is, like the medical term for it. But this one only lists them by the brand names. So here's the thing. I have to understand what this means, because you can see my drug, which is called Enbrel, is listed, and there's bazillion different formulations of it. And then look at all these acronyms. So I'm going to help you understand what these kind of are. So in the case of mine, there are two different delivery mechanisms for my drug, which once again, they just keep changing the shape of the syringe to extend their patent. But I take now not the SureClick, which is this one, which is the one that most people get prescribed under. The SureClick has an automatic injection format, and it's also called a pen, and it's the way that a lot of specialty drugs that are self-injected are delivered, and that's because it's pretty foolproof once you get over like the fear of needles and stabbing yourself, and you get like trained by a nurse, which all these specialty drugs have like nurse hotlines, because it's a tax write-off for them. Once you learn how to do it, it's pretty foolproof, because you just click a button and it goes in. They changed the syringe in order to extend their patent, and then I started having a bunch of technical problems with them. Also, I found them more painful, and then the downside, as I learned when I first got on this drug, was that I flinched with the pin, but you can't stop the flow because it like clicks into place. And the other thing is they're really big, so they kind of suck for traveling, because there's this big piece. I actually have some. I keep looking over there because they're like in the fridge. But they suck for me for traveling, so I actually switched to the pre-filled syringes. And the advantage of that is because there's not also the patent for the auto-injector, the cost of mine are lower overall now that I'm on the pre-filled syringes, which take a little bit more like mental work or whatever to do, but I'm very used to them now. So what are the various things we're looking at on this page? One, I'm trying to make sure that there is the availability of this drug. Often you'll have the dosage amounts, and this is where people can run into the problem that was being mentioned earlier by David, which is that sometimes insurance companies will only cover one type of a drug. You see this a lot with controlled substances. So, for example, like Adderall, which of course has generics of it, but there's what's called Adderall XR, which is the extended release version. The extended release for Adderall is a lot of people find that it works a lot better for them, but quite often it will not be covered under a formulary, or you might get approved to get Adderall in the non-extended release format where you have to take it like multiple times throughout the day, but you have to get another level of approval to get approved for the XR, which means that your psychiatrist, in the case of Adderall, in the case of some other drugs, it might be your primary care physician or your specialist, is going to have to write to and appeal to the health insurance company in order to try to get it covered for you to get, like, to demonstrate why you can't take the other dosage of this drug. So in my case, I take the 50 milligrams milliliters version of this drug. So, okay, I found it on there. I'm like, great. I found this Enbrel, like, coverage, feeling good about that. I lost it again, y'all. Why is it so hard to search a giant PDF? Notice that they make this like as hard and as complicated as possible to make you like feel very frustrated. Okay, so what does this number mean? Well, what this number mean, if we go up to the top, it'll say what the drug tier is. In my case, the drug tier is 5. Like I mentioned, it's quite common to have 4 drug tiers, which will usually be like preferred, generic, and then non-preferred generic, and then like brand name, all of these. And then it'll be like more expensive drugs, and then it'll be specialty drugs, which is like the 7th ring of Dante's Hell. And specialty drugs are often called either specialty or they're called tier 5, sometimes called tier 4, just to make it different, because every health insurance company is different, just to make it like worse. So what does that mean when it's 5? Well, there's a couple different things we need to see. One, we now know that this is 5, And then we also know that it's got these two other limitations on it. It's called PA and NDS. What the fuck do PA and NDS mean? Well, these are acronyms that are often similar with different health insurance companies. By the way, this is a 128-page document. It's actually not the worst laid out formulary I've ever seen, so I will give them points for that. But if you go at the very top, it will usually explain, in addition, like what their tiers are. So tier 5 is specialty tier drugs. The tier includes both generic and brand name drugs. And then tier 6 is their own special tier. I've never seen that one before, but essentially it's for injectable Part D vaccines. We don't need to dig into that. It's meant to specify things for Part D Medicare, and we'll just we'll move on from that and we'll deal with that later. Okay, but what it will do is it will include a table or something like that to tell you what these acronyms mean. So HI would be a home infusion drug. So a home infusion drug might be something like chemo. It could even be home dialysis, although usually they don't call those infusion, where you will actually have a provider come to your home and provide the infusion rather than going to the infusion center. The home infusion drugs may be covered under a medical event benefit and obtained at home infusion pharmacies. Usually what that means is that you're only going to have certain pharmacies that you can go to. LD are limited distribution drugs that can only be obtained at certain specialty pharmacies. For more information, consult your pharmacy directory or call our plan. So LD drugs, or often they're called SP drugs, which stands for specialty. The acronyms are different for everyone. Usually means that you're going to be required to go to only certain kinds of pharmacies. Some of those types of medications might be pain drugs if they're requiring you to only go to a pain clinic. And that's because they're controlled substances, that they're subject to diversion requirements under the FDA, because, for example, like opioids have a high risk for diversion and abuse, and therefore they make people go to these pain clinics and beg for them. This also applies to methadone and other kinds of drugs that are used in recovery. So they can be a pain in the butt because you might have to go there like every day because you can only get like 1 day's dose. Or 1 week's like dose. It's very annoying. But it also might be someone like me that can only go to a specialty pharmacy. So in my case, I don't currently have an HMO. I have a PPO. However, because of the conglomeration in the world of medication and health insurance, I can only go to CVS specialty pharmacy. So on a PPO, you usually choose it because you have more choice. But as soon as you have an expensive condition, you have almost no choices. So my choice is that I can go to CVS, Caremark, specialty pharmacy, or nowhere. I either have to pay out of pocket or I go to the one pharmacy. And what does that pharmacy have? It has a pharmacy benefit manager that does things like try to investigate if I'm using copay assistance and not count it towards my deductible. And be a pain in my ass. Just to be clear, this concept of specialty drugs does not exist under other health insurance systems. It only exists in the United States because they decided it's expensive. That doesn't mean that other systems don't have prior approval or formularies. Like, you can pretty much search for a formulary on any socialized healthcare system in the world. However, this concept of like you pay more when the drug costs more is like kind of a uniquely American thing where it's like, oh, we want to like prevent people with expensive medical conditions from accessing costly treatment by making them cover more and more of the costs, despite the fact that people with expensive drugs most likely have the highest cost care burden anyway because they have to access more healthcare to stay alive. But anyway, so that's what an LD is. MO is something you're going to commonly find because, especially on things like HMOs, they will only let you get things by mail order. But the advantage of that is that mail order is usually costs a lot less and is pretty convenient for a lot of people. There's just certain drugs that you may not be able to get via mail order. A great example is mine because it's refrigerated. I have to go. I have to get it. Either if I do get it mail order, it's going to come to me overnight and it's not considered a mail order drug. So the other two things that I had was what was called NPD and PA. And I know what PA is, but I'm trying to find where they've listed it on this freaking formulary, because you'd think that they would have to list how they define something. And I can't just search. There we go. Let's go to the bottom. See if we can find it. Anybody have any questions as I rant here? This is just like all the translation lines. Come on. Nurse Hotlines is the name of my next band. Philip says, so incredibly useful for me. Thank you for suffering through the frustration of figuring this stuff out so that you can share it with us. I haven't figured it out. I've just tried to figure it out. But the good news is that there are a lot of benefits. Geograph Concept says you have to talk about Humira biosimilars coming out next year because I'm terrified it will destroy my life. One, please don't be super concerned about it destroying your life because stress is bad if you have an autoimmune disorder and you can't control it. But the other thing I will say is that patient advocacy groups, so particularly the Arthritis Foundation, which is mainly a patient lobbying group, is conducting a survey right now about people with autoimmune disorders and their concerns about the approval of the biosimilar and what things they want to ensure. One of those cases being like, are they concerned about being switched to it without being informed? Are they concerned about like if it doesn't work for them that they're not going to be able to get on it? And I highly recommend going and filling in that survey. If you don't have arthritis or like an arthritis condition, but you are affected by the Humira biosimilar, one, it's okay. Go fill in the Arthritis Foundation survey. Two, go check in with whatever the patient advocacy group is for your condition. If you are someone that has such a rare condition that they don't have their own patient advocacy group, there is the Rare Diseases organization, which is the lobbying group essentially for, it's like the umbrella organization, and they are also doing some lobbying around it. The frustrating part is that this all is going to have to happen at the state levels for more than 50% of people because they're getting their insurance at the state level. So anything that we can pass federally, which is almost damn near impossible now with the problem that our legislature can't pass anything. Anyway, because of like everything has to happen either state by state, and like we tried to get a copay accumulator ban in Oregon, and we couldn't get the bill that we had like out of the state like legislator out of the committee, even though we had co-sponsors, because our legislators make like $3,000 a year, and like nothing, like way below the poverty level, and then they get like a per diem, but it doesn't add up to a lot. And they need the support of the health insurance lobbies to keep them in place. Anyway, sorry. Page 5. Thank you. Sorry, I'm doing a rant here. I like how you already went so far into it. 5. Where did it go? Wait, I'm on page 5. It must be a different part 5. Oh, there we go. Oh, I like that they didn't even define that it was PA there. Okay, so PA is what is called, PA is covered, PA is prior authorization, which means that your doctor is going to have to send in a document in order to get that drug approved for you. So because I end up inevitably switching insurance like every freaking year because America, every January I go into I've never been on an insurance that hasn't required prior authorization for my very expensive drug. And the prior authorization means that my health insurance company essentially, or that my provider, so in my case, the rheumatologist's office, will send in paperwork proving a couple things. One, that I've failed on the cheaper medications. Two, that I have the right diagnosis for it. Which is another thing you can often find on the formulary. It will say what kind of conditions are approved for this drug. And then the third thing is that, like, in my case, it's that I've already been successful on this drug. Otherwise, it might be the doctor's, like, paperwork showing that, like, this is successful for someone with this diagnosis or with this condition. If the prior auth does not go through, if you get a rejection on the prior auth, you have to do more work, but that doesn't mean you might not get it covered. So for my case, luckily have a pretty straightforward one because I've been on this drug successfully for 8 years. It's a first-line treatment for my diagnosis. But if it was rejected, then what would happen is that your doctor has to go back to the insurance company with an appeal. And what they need to ask for is what is called a peer-to-peer review. And a peer-to-peer review means instead of talking to a bureaucrat or a computer, which is usually who does the first round of prior authorizations, they will instead talk to a medical professional. And this is usually a medical professional that sold their soul by working for insurance to deny coverage. Sorry. I'm being mean, but there's a very good video. Dr. Glockenfleckham, who is a doctor who does like a lot of skits on TikTok about insurance and like healthcare. But Dr. Glockenfleckham had one where it was like the peer-to-peer reviewer, medical reviewer was like a doctor who lives under a table and is told by bureaucrats to reject everything and then gets like a free pen every time you reject something. Anyway, a peer-to-peer medical review just means that the doctor will say, like, hey, a doctor needs to look at this record and say that this isn't effective. If that fails again, that isn't the end of the road. There is another type of review you can do, which is called an independent review. And that will be someone that is contracted by the health insurance company, but is actually an outside medical doctor that does not work for the health insurance company, unlike the medical reviewer, that will have to evaluate it. And that person is also a medical doctor. And because they are also a medical doctor, they will do a review of like what is available. They will do a review of the documents. Probably at that point, your doctor, hopefully who is like all rheumatologists essentially will have an administrator on staff to help with all the paperwork. And like, same with like GI doctors, because first line treatments for them are usually biologicals and infusions, very expensive, costly things. They will have an admin who's very organized and they'll add more documentation, but then that independent medical reviewer will then have to review and see if they agree with the original doctor or they agree with the insurance company's medical reviewer. And then if that has failed, you can keep trying to appeal, but that is the point at which usually your options are pay out of pocket. So that might mean fundraising from family and friends, going out of state, going out of country even, like people that go to Mexico or Vietnam to get their drugs or medical procedures, go to India for medical tourism, Thailand, any of those places. Or your next option is to kick up a shitstorm in the media. So at that point, there is a series of processes that kick in at the insurance company where they absolutely hate it when the news has like the child that's dying because they won't get approved for a lung transplant on the news and they don't like being shamed. And the cost of being shamed is usually worse for their PR people than it is to approve the procedure. But they actually have people who weigh the cost of that shitstorm. So those are the options. So I'm on page 5 of the comprehensive formula, not the specialty formula. Why can't I find the NPD in here? Maybe we're on a different years. Okay. I still don't see NPD anywhere. What are they defining it as? Can you just tell me? So yeah, cost of being shamed is greater than the cost of drug itself. Usually the kind of shame is getting to that shame point is usually like you need to make sure you have a good and compelling story, unfortunately, to get the media to pick it up for it. But it is an option. This is a thing that a lot of people have to deal with because there's a bunch of different insulin types, and insulin, one, is a life-saving requirement drug, but it's also very expensive in the US because the companies are allowed to profiteer off the cost of insulin. Insulin is one of those cases where different people react differently to different brands of insulin, and different brands of insulin work differently with different kinds of medical devices like pumps and stuff like that. And this is one of those cases where they're going to have their doctor, which would be is that an endocrinologist that works with someone with diabetes usually? I think it's an endocrinologist. Correct me if I'm wrong. But they have to go and they have to fight on behalf of getting that particular one and show that like the other types of insulin won't work, whatever. NDS is non-extended day supply. What the fuck does that? I actually don't know what that means. Not NPD or Neil Patrick Harris. What is NDS? What does that mean? What does non-extended day supply mean? This is a perfect example. I spend so much time on this, and I'm writing a fucking book on this, and I still don't understand what some of these terms are because they change them for every damn like these are written by lawyers, and you have to be like a lawyer to fight them. Okay, well, I'm glad people are finding this helpful. Eric says, such an adversarial way to present your benefits. I agree. Atabay says, this is great news. With the new meds and copay assistance, I should hit my max ASAP. My max out of pocket is $15. Oh, right, you have Medicaid. That's great. So the thing I do want to emphasize, though, Atabay, you need to check to see if you have a copay accumulator in place. Because if you have a copay accumulator in place in your state, like in your health insurance plan, then whatever is paid towards the copay assistance will not count towards your out-of-pocket maximum or your deductible. So then you're going to have to pay for your own stuff. And it'll be as though you have never met the deductible. So it's like important to understand like whatever they pay on your behalf, if there's a copay accumulator in place, which they are also allowed to implement mid-plan year, which I think should be highway robbery. That's why it's important to investigate it if you are getting copay assistance, or to at the very least not make your decisions about your healthcare plan as though it is going to count towards your deductible and out-of-pocket maximum, because increasingly fewer and fewer plans are available without a copay accumulator getting in place, which is partially to do with the fact that there is fewer and fewer pharmacy benefit managers, and we have gotten rid of it. So because of the one part of it is because they allowed health insurance companies to do it based on the 2021 HSS ruling. But the other thing to know about it is that there's fewer and fewer pharmacies available because there's massive conglomeration in the industry, and they all have pharmacy benefit managers. And because there's fewer and fewer available, you're more and more likely to get one of the specialty pharmacies that has a PBM, and PBMs and the implementation of them are sold to either employers that are buying self-insured plans or health insurance companies as a way to save money, as though we're just such terrible, terrible people that we don't have thousands of dollars a month to spend on our drugs. So yeah. NDS, dispense up to a 30-day supply to monitor for side effects and avoid waste. So that's usually written as QS, which is quantity limited, or QL. So usually it's written as a Q something. I don't know why I couldn't find it. I must be on the 2022 one. I am. That's why you're seeing different things. Thanks. I just picked the first one when I Googled. So that is a thing to understand. Sometimes it'll just write they'll write 28, but if you're on an expensive drug, it'll usually be quantity limited. For mail order drugs, they'll often let you get a 90-day supply. But if your drug is expensive, they claim it's to monitor for side effects, and it might be. It also might be because it's a controlled substance, and so there's requirements for diversion because they don't want you to get 3 months worth and make your life easier as someone who's getting a controlled substance for your pain and or your executive dysfunction. But they want to make sure that the drugs can't be diverted, so they won't give you a lot at once. It's also just to punish sick people, but whatever. But when it comes to my drug, I have to get a TB test once annually to get authorized for the drug, because you can't be on an immunosuppressant if you have latent TB. But also TB tests are not that effective. But anyway, they're not a very effective test. But I have to get a TB test, and then I also have to get a CBC once a year. But other than that, I don't have to get my liver levels checked or anything. The reason they quantity limit my drug is because it's too expensive. And so they don't want you to accidentally get more than 28 days. Philip says page 7 in 2022 PDF. Thank you. So that is a great example. One last thing to say about formularies, as though I haven't talked about them for half an hour already. An important thing to know with formularies is quite often they will list what conditions they are approved for on there. And this can be really important when it comes to diagnosis. So even if you have a drug that is approved on the formulary, but it's approved for a different diagnosis than the diagnosis you have, you may have to go through an appeal process, a prior authorization process, or it may not get approved. And if you are someone that is getting what is called an off-label prescribed use of a drug, so a great example of an off-label use is that birth control can often be prescribed to people for acne. So that's an example of like an off-label use. It's a little weirder because birth control is actually like covered as a preventative benefit under the central health benefits, but we'll move on from that. So let's say that you're getting a drug, but you're getting it for something other than what it is usually designed for. Sometimes your doctor can just change what they say that it's being prescribed for. And in the case of birth control, that might be an example of something where it's just easier to just change it. Another option is that they will have to demonstrate through the peer-to-peer medical review that there is evidence in literature of this drug being effectively used to target your thing. So it might not be listed on the formulary, but if they can produce the literature saying like, hey, we found this heart medication also happens to be good at controlling symptoms of bipolar disorder or something like that. Like anticonvulsants are commonly used to treat schizophrenic episodes, despite being like two different disorders. And so in that case, they can present the literature, they can present evidence that this has worked before in the medical review, but it might initially get rejected because you don't have the right diagnosis. In my case, I was originally diagnosed with rheumatoid arthritis, and then like 8 years after I got diagnosed, my mother, who also has the same thing as me, said, hey, actually, they did this test and they found out I have this other diagnosis, which is a much more rare disorder. It's rare diagnosis. I wouldn't say disorder necessarily, but it's a more rare diagnosis. And it is seronegative peripheral spondyloarthritis. And because of that, even though she got that gene test, said they actually changed my diagnosis to this, I told my rheumatologist, hey, it's not a big deal because the treatment protocol is the same, but like should we get this test on me to see if maybe that's actually what I have? Because I've always had what's called seronegative, which means that certain blood tests don't show up with like a SED rate for me, which means that I present an atypical diagnosis for rheumatoid arthritis for someone of like my age and my sex. But it's a clinical diagnosis as well. And like, I very clearly had the symptoms of it. So I got the gene test for this gene and it was positive because once again, this is hereditary. My mom had it, her mom had it. And because of that, technically I could have my diagnosis changed. All of this adds up to, even though the diagnosis is the same, because my current treatment for my current drug is effective and it's for a relatively common disorder. So rheumatoid arthritis is like on every formulary. Like it's a known, people have had rheumatoid arthritis and we have known it in medical literature for hundreds of years. And so it's on every formulary and the drug that I'm on is first line treatment for it. However, the peripheral spondyloarthritis is rare enough that, especially in women, because it's more commonly diagnosed in men, it's more commonly diagnosed as axial spondyloarthritis. All of this to say, she was like, we're not going to change your diagnosis on your record. And that is because don't rock the boat if you're already getting this. However, she may change it if the drug I'm currently on stops working for me. And that is because there are drugs that only are effective on that type of spondyloarthritis, which is my actual diagnosis, my new diagnosis. There are types of drugs that are a different kind of biological that target a different, smaller part of the like receptors in. I'm on a TNF inhibitor now, and this one is like, it targets an even smaller part of the tumor necrosis factor in your immune system. And because of that, it only works for people with that kind of spondyloarthritis. And it's also prescribed to people with, what is it called? spondylitis. Sorry, I'm very bad at pronouncing that. But she said, if Enbrel stops working for you, then we will change your diagnosis, because then we'll be able to get you approved for this other drug that you wouldn't be able to get approved for with just a rheumatoid arthritis diagnosis. Atabay says, found my drug, level 5 with prior authorization with Blue Cross Blue Shield Texas. Thank you again so much for all the info. Great. So if you find the tier that is listed under, that will also tell you what the copays are. So a great example is if you go in to these summaries or the plan care, they will usually tell you what your cost for drugs are based on the tiers. And there's usually 2 different options. You'll either have co-insurance or a copay. It's quite common that the copay is very low or even $0 for a lot of generic drugs. Why can't I find drugs? Am I just spinning too fast through this? Here, sorry, I just realized you guys are not on here. Okay, diagnostic and x-ray, benefits, skilled nursing facility. Okay. Why can't I find the drug lists, y'all? Okay. Physician services, preventative health services. Why does it... This should not be this way. Okay, here we go. Here's the drugs. This is for the Kaiser plan. So I have a $0 deductible, so I don't have to pay anything out of my own pocket except the copay. But you can see, like, for me, since I have a tier 5, a specialty drug, I do not pay a $20 copay for retail or a $40 copay for mail order. So the reason the mail order copay is higher is that usually it's for a 90 or a 60-day supply. So even though it looks like, why would you pay more for mail order? It's usually actually because you're getting more of the drug available. But the specialty drug, notice it isn't $20. It's 20% co-insurance. So what is important here? One, it has a cap. So it has the cap of $200. The other plan I was looking at had a cap of $150. So I was like, okay, that's great. I already know that there's no way my drug is less than $800 because it was $800 8 years ago with this same plan. So 20% co-insurance, the $200 is what I'm going to pay because there's no way that it's less than $1,000. So I will be paying $200 a month if I get this plan, because that's the cap. However, if you do not have a cap, you need to go find out how much that drug is going to cost. And this was the thing that was really frustrating to me because I called Kaiser to be like, I need to know how much this drug is. A lot of insurance companies will have like an online portal where you can search what the average cost of a treatment or a provider is. This is actually one of the things that's now like required under full transparency, but it can be really hard to find. And then Kaiser did not have that. And I called on the phone and guess what? After me dealing with, I called like the specialty people, and then the specialty people put me on the line when they called the specialty pharmacy. And this damn company could not tell me how much the drug cost. And you know what they decided to tell me? They found my record from when I was a patient there freaking 8 years ago. And they were like, well, you paid $40 then. And I was like, okay. Telling me how much my copay was when I had a different plan and a different employer 8 years ago tells me literally nothing about the cost of the drug. Another option for you can be, if you want to find the cost of your drug, you can actually sometimes just Google the cost of the drug. First, I would try like search, like, so let's say you have Blue Cross Blue Shield drug cost. You can always try calling member services. So for Blue Cross Blue Shield Oregon, no, wait, I had California. California Blue Cross Blue Shield, which is what I had this year. I was able to call up and they were able to look it up. And they were like, oh, do you want us to see it? Once the poor lady on the phone, when she saw how much it was, she was like, oh, so that'll be $10,200 or whatever. she was like, do you want me to look to see if there's any cheaper drugs that are considered like equivalent? And I was like, sure, you could go look. And I knew the only other drug that was going to come up was Humira. And she was like, oh, yes, you have another drug that only costs $9,700 or whatever. And I was just like, come on, y'all. But you may be able to look up like and find the online things. You can try calling member services. You can try just directly calling the pharmacy. One of the problems I find when you're doing research on a plan is often they can't help you if you're not currently a member with drug costs. But then there is one other option. If you want to find the high end of what the drug cost might be, what you can do is go to GoodRx. So GoodRx is a thing that you can use to get prescription drugs. If your insurance, it costs too much on your insurance. However, it's like the opposite of using your insurance. So it doesn't work for, usually it doesn't make any sense for really expensive medications, but it is worth searching because it's essentially a coupon that you can go use. And so one of the options with GoodRx is that you can see the retail cost of the drug on here. Your insurance will usually get a lower retail cost of the drug than whatever is listed on GoodRx. So don't pay attention to what their free coupon is. This is, by the way, what they're suggesting for a 28-day supply as being a discount. Yeah. So anyway, this is, but you can go look it up if you want to look at it. All right. Malin says, thanks for the info. Great stuff. It's time for a pint and indulge in a bit of bubble and squeak. Thank you very much. And also, I should probably be done too. So, because I need to like clean my house and stuff today, y'all. I still have some deadlines. Thank you all, though, for joining. And I appreciate that you let me go on for 2.5 hours for this live stream. And once again, it is Healthcare Month, so I will do another stream about this. But if you do have any questions at all, feel free to come join over on forum.ohmydollar.com and ask questions, and I will do my best to answer them for you. I am semi-experienced at this, and I at least know my way around this stuff, and so hopefully I can help. Geograph Concept is going to go take an exam. I'm sorry. Nice and depressing for you before the exam. But go check out forum@ohmydollar.com. If you do have any questions about health insurance or want help weighing out the cost, I and some other people can probably help you on that. And we will probably do another stream on health insurance and probably a podcast as well. So thank you all very much for joining today. Stay safe, stay healthy, stay hydrated, and I will see you all again, same time, same place next week, unless you're in a country that observes daylight savings time later than America. And just stay safe, and I'll see you all soon. Bye.